Well, thanks again for tuning into the Unabridged MD podcast. Be sure to subscribe so you can be notified when the next episode is up. And as always, if you think that this would be helpful for a friend or family member, please share. Wishing you wellness. Until next time, take care. Well, hello everyone. This is Dr. Amigues, your friendly rheumatologist. I'm putting the live on Instagram, and I'm all yours. And today I want to share. A story, and I want to explain why it's important to see a rheumatologist that's going to listen to you. And it's coming from the frustration that I've seen recently with some of my patients, and it's really sad for me, and it's really sad to see a patient start just because they see me basically realize like that they had been gaslit this whole time, and it's not the fault of my colleague. I think it's the system. So let me tell you the story. So basically, let's say you have developed joint pain, and it's inflammatory, and it's worse in the morning, and it's associated with morning stiffness, and you have swelling, and then you finally, it takes you, I don't know, 3-4 months to see a rheumatologist. You see that rheumatologist, and they diagnose you, let's say, with rheumatoid arthritis. Okay, that's great, but number one, you've already lost 3 months, right? And the issue is, we know that the earliest you treat rheumatoid arthritis, the better you're going to get outcome when it comes to the rheumatoid arthritis. So what I mean by that is that you're going to get to remission faster, but you're also going to have less erosion, less complication from the rheumatoid arthritis. But let's say, okay, you've been diagnosed and you start treatment. The problem is that in the current setting of insurance is that doctors don't get paid if they call you. And they also don't have the time to see you because their schedule is fully packed. And so you start this medication. We're telling you to take methotrexate, and your doctor is like, anyway, we need to give methotrexate because otherwise the insurance won't agree on doing anything. Well, the thing that's very important is to realize, yes, we have to try methotrexate very often because insurance asks us to. But it's not true that you have to be 3 months miserable on methotrexate. So we always try it unless you have a contraindication, because we want to make sure that it's not going to work. You know, in the literature, 2/3 of patients will get to full remission with just methotrexate. In my clinical practice, I would say it's about 1/3. Okay, well, 1/3, that's still a great number. If that's all you need, that's great, right? The issue is that, and I think that that's the problem, is that people don't explain this, is that if you cannot tolerate the methotrexate, no one is here to force you to keep methotrexate. And you absolutely should start working with your insurance and getting the next medication that they will allow to get. And so here is this some of our poor patients who are waiting, who are basically saying, hey, methotrexate has caused me nausea, it's caused me hair loss, and I don't want to keep on it. Okay, well, sure, you should not be on it, but also we should treat you. And what I've seen is basically the patient will be on prednisone forever with no plan on decreasing it, because we are afraid of their insurance, when really the goal here is get the treatment, and if the methotrexate is not tolerated, move on to the next medication that maybe maybe their insurance would say, okay, try another DMARD. So maybe you try the plaque inhibitor, but we know it's not going to work very fast. And so you may try, but you have to talk to the insurance. And the truth is, you can also ask a drug company for a bridge. So if you're thinking of a TNF inhibitor, you may actually have the drug company allow you to use some samples or something until we reach the famous 3 months of insurance. But that's number one, is you do not have to be on a medication that's causing you trouble. So I think that that's really, really important. Most of the time, it does not cause trouble. But if it does, we can switch to another medication. So that's number one. Number two is prednisone. If you are being offered by your rheumatologist prednisone, there has to be a plan on how to stop it. How do you stop it? When do you stop it? What's the goal? The third thing is you've got to understand the goal of treatment. So the goal of treatment is, and that's true, we usually start with methotrexate. Try methotrexate. If that doesn't work, or if it's not well tolerated, so work will be assessed at 3 months. Usually I assess at 1 month, can I increase it, right? So we increase it all the way to, the maximum dose is considered 25 milligrams per week. It's a mini dose in comparison to some other use for methotrexate, but it's still a maximum dose for rheumatoid arthritis. But you're so you're trying this at 1 month, you evaluate the efficacy and the safety. Are you well tolerating? Are you tolerating this well? Then you go up on the methotrexate dose. Is it still well tolerated? Is it efficacy? What's the efficacy? Are you in full remission? Yes, no. If no, and then at 3 months, if you're not in minimal disease activity or remission, so how do we define this? No more joint pain, no more joint swelling, no more morning stiffness or less than 15 minutes, and no fatigue. And the inflammatory markers are normal. If you, my hand is going away with the backdrop that's not my house. I don't have a grand piano. But basically, those five, if you can have one of those five. That would be called minimal disease activity. But if you have any more than one of those, you are not in minimal disease activity. And so we have to switch treatment. And so the way we do it is that we add a biologic. Okay, so we add biologic. Usually we start a TNF inhibitor. And again, either you tolerate this well. If you don't tolerate it, we switch. We don't wait 3 months. That I don't know where this 3 months comes from. I mean, I know where it comes from. It's the efficacy. If you tolerate it, then we want to see the efficacy, and we assess it at 3 months. If you do not tolerate it, we switch, and so we switch to another biologic or a small molecule, and at 3 months again we switch. Oh, did I lose my connectivity? My connection it's unstable. I apologize for this. I'm at the Boulder office. I apologize for the connection if it's not good. I'm not sure why. I have very good connectivity here. But yeah, so basically, it's very important that you realize that. What I see is some patients that have gone through the system, and after 2 years, they are still not in remission. And they have no plan on how to get to remission. And if they've gotten into remission, they suddenly stop the medication, not realizing the way that we're supposed to decrease the medication. And so this is important to me to explain this to you, right? It's like, one, you want to be seen as soon as possible. Two, the plan is full disease remission with medication. Three is, how do we get you to full remission? And then what's the plan to decrease the medication? Full remission, minimal disease activity, has to be assessed off of steroids. If you need steroids, so if you need prednisone, if you need Medrol, and that's not remission. I'm so sorry, but that's being in remission with steroids, which is not good because steroids have a ton of complications, right? They're associated with a ton of complications. So let's look at that, right? What's the goal? How are we going to decrease the steroids? Let's make sure that we do it safely, because if you've been on steroids for a year, chances are your adrenal glands are not used to making the steroids that you need for the proper function of your body. So we need to slowly decrease it. Make sure you don't have adrenal insufficiency, okay? And then the fourth thing is, let's make sure we talk to you about how those biologics work, how the small molecules work, and what's the goal once we've gotten you to full remission, is how do we decrease that? What's the goal in decreasing those drugs, and how can we do it safely? I always say to my patients, the first goal is to put out the fire, because that fire, if you have rheumatoid arthritis, for example, you're going to have potentially, you're risking eroding your joint. So destruction of the joint, deformities of the joint, but you're also at risk for cardiovascular disease, so for myocardial infarction, for heart failure, for hypertension. You want to take care of all of that, right? We want to decrease that. So we want to get to remission. Once you're in full remission, then we wait a little bit, and then we start backing off. First and foremost, you want to back off from the steroids. I usually try to avoid steroids oral. I sometimes give an intramuscular just because it's a one-time thing. I don't want my patient to suffer. And we know that it can help at the beginning, right? But then we want to back off from the steroids, okay? And then after that, we want to get you with the least amount of medication, but safely. I was sharing this with someone. If you're on just Humira or adalimumab, and you're doing like really good on that, we want to back off. But the way we're going to back off is we want to make sure you don't develop antibodies against the drug. So we may need to give a little tiny dose of methotrexate to prevent the antibodies formation against the drug, right? And that's how we do it. But those are discussions you're doing with your rheumatologist. You need a rheumatologist that has the time to explain their knowledge to you. So you understand where you're going. So you understand where you're going when you're going for full remission. And you understand where you're going when you're backing off from treatment. Okay? That's super important to me. I know that sometimes patients think that they're saving money by going to an insurance-based rheumatologist. As good as rheumatologists can be in the insurance-based model, they do not have the time than direct care concierge rheumatologists will have. That is just the way it is. And I've had some rheumatologists complain to me saying, well, you're giving so much of your time to the patients and are used to that. You know what? Yeah, like the goal is to elevate the rheumatology care, not to decrease the care that I'm offering. I'm sorry, like I think patients deserve better. And yeah, that is true. You're not gonna have 60 minutes, 1 hour and a half with a rheumatologist that's in the insurance model because insurance cap their time, and they don't pay properly the physician, and they are starting to pay them less and less, and that's ridiculous. You cannot expect your rheumatologist to offer you good care if the only time they have to spend with you, and that's not their fault. That is not their fault. That's the system they are in. But if the only time they have with you is 10 minutes, that's just not going to happen. They will not talk to you about how to back up from treatment. They will not talk to you about the latest research that's out there. They just don't have the time. And I can assure you, they would love to do that. They just don't have the time. So in a way, you're going to save money, but most importantly, you're going to save time by going and seeing a rheumatologist in the direct care model. This is the new way. This is one of my colleagues is opening another direct care practice in Denver. This is the new way. This is the way that we offer good care to our patients. And that is actually saving you time, but saving you hope, saving you health, and saving you in the long run. And yes, it's an investment, but it's a good investment because it's an investment for you. Okay. So that's my recommendation. And I seeing my patients basically realize that I'm feeling so sorry that they didn't find me before. I'm really sorry. I wish I had been there before. I wish I would be in the front of people more so that that you can see me. It's important. I really think it's important. It's important to see you early and to talk with you so that you understand what we are here and what we're here for and what we're doing. Okay. I'll see you next week. Next week, actually, I'm probably going to do a webinar on the parasympathetic system, how to stimulate our parasympathetic system to help with inflammation. If you're interested, sign up. I'm doing it again because it was so well received that I want to make sure that if you're interested in learning about it, you can have access to it. And we are also starting a cohort of patients with inflammatory arthritis and autoimmune disorder that want to heal together with me as the the person that's opening and creating the space for your healing, and also with health coaches, nutritionists, experts that can respond to your question, and most importantly, a group, because healing as part of a group is much more powerful. Okay? I'll see you next week. Take care. Thank you for listening, and bye bye. And if you're watching this, I'm so sorry, I didn't say hi to everyone, but if you're watching this live, hashtag live, and if you're watching this on replay, hashtag replay, and share this with someone else, okay? Take care. Bye-bye, everyone.
Well, hello, this is Dr. Isabelle Amigues, and welcome to the Unabridged MD podcast. Here we explore inspiring stories, practical tools, and expert insights for living a healthy life. Whether you're a patient, a healthcare professional, or simply curious about healing, you are in the right place. And as always, if you are looking for something that's so much bigger than just a rheumatology practice, please come check Unabridged MD, as we are the right place to get you to remission with the least amount of medication. With that said, let's dive in.